We're now going to talk about stones. And we have a couple of vignettes. A 72-year-old man who in previous years has passed a total of 3 urinary stones is now again having symptoms of urethral colic. He has relatively mild pain that began 6 hours ago and does not have much in the way of nausea and vomiting. CT scan shows a 3 millimeter urethral stone just proximal to the uretrovesical junction. Urologists have a bewildering array of highly technological ways to deal with stones. Stones can be shattered with sound waves, stones can be destroyed with a laser beam, stones can be extracted with a basket, stones can be operated on and removed. But that doesn't mean that every single patient that is passing a stone requires that kind of technology. If we have a very small stone like this one, and it's already negotiated most of the ureter, it's perfectly appropriate to let it pass. So here we have a CT scan that says that stone is only 3 millimeters in size and it's already at the uretrovesical junction. CT scan, incidentally, has become the best way to diagnose urethral stones. Any teeny bitty amount of calcium a stone would have gets picked up by the CT and makes it visible in the CT. This man can be simply be given medication for pain, plenty of fluids, and let him pass the stone. But on the other hand, a bigger stone higher up would not be appropriate for that approach. Let me read the next vignette. Vignette 26. A 54-year-old woman has a severe urethral colic. CT scan shows a 7 millimeter urethral stone at the uretero-pelvic junction. Let me adorn this with a few numbers. The 3 millimeter stone we read about before has about a 70% chance of passing on its own. A 7 millimeter stone has about a 5% chance of passing. That would not be a good strategy. And out of all of those technological ways we have to deal with the stones, probably the one most commonly used is the extracorporeal shock wave lithotripsy. So this lady is put on that water bath through which the sound waves are transmitted, the stone is shattered, and the little pieces are passed. And as long as we're talking about the extracorporeal shock wave lithotripsy, let's remind ourselves of the contraindications. We do not use it on a pregnant lady. The baby would not appreciate all the noise. We do not use it if there is a bleeding diathesis because we might precipitate bleeding in the setting. And it is not a good idea to use it either for very large stones, like a staghorn calculus that fills the intercalating system, because then if you shatter that, you're going to have dozens of stones of the size of the one we're talking about on this vignette. So this one is a good candidate for extracorporeal shockwave lithotripsy. A much, much bigger stone would not be. Let's look at a few pictures of stones. This is a large stellate urolith. It looks to me like this one is already in the urinary bladder. Here is a staghorn calculus. And this is a good example of the kind of stone you do not want to shatter with the sound waves, because it is too big and it would generate too many little pieces of stones. Here is hydronephrosis, secondary to having a stone occluding one side. It's a good example of how good the sonogram is to detect the hydronephrosis. And the last picture, reminds us that we can, with the use of ultrasound, also remove stones, because the ultrasound can be used to shatter them. There is a probe that will do that. And this is the end of stones.